Welcome to this podcast from the Medical Journal of Australia. My name is Sally Block, the MJA's news and online editor. The MJA acknowledges the traditional owners and custodians of the land on which we live and work across Australia. This podcast was recorded on the lands of the Wangal people. I pay my respects to their elders past and present. Emergency laparotomies are performed on thousands of Australians each year for critical conditions like bowel obstruction and peritonitis. It's a high-risk procedure with a mortality rate of 6.9%. Now, for the first time in Australia, a national clinical care standard has been published by the Australian Commission on Safety and Quality in Healthcare. It's to support clinicians and healthcare services to deliver best care and improve patient outcomes. To talk to us about the standard is Professor David Watters, AM OBE. He is a distinguished Alfred Deakin Professor at Deakin University and Barwon Health and Director of Surgery at Safer Care Victoria. I'm also joined by Dr. Chuan-Whei, Staff Specialist and Joint Clinical Lead of Perioperative Medicine at the Royal Melbourne Hospital and Clinical Senior Lecturer in the Department of Critical Care at the University of Melbourne. So, David, why do we need a clinical care standard for emergency laparotomy?
Well, patients who have an acute abdomen and need an emergency laparotomy are probably in the highest mortality group of any patients being admitted to public or private hospitals. And there's a fair amount of variation in the standard of care and in the outcomes when we look at outcomes and treatment of emergency laparotomy. We've already seen from the UK, from their National Emergency Laparotomy Audit, that having an audit and having a standard there that people try to meet against best practice is actually resulting in both shorter length of stay and reduced mortality and better outcomes. With our own registry in Australia and New Zealand, we've also seen in the early years some trend of improvement, but when I was chair of the Victorian Perioperative Consultative Council, we wrote from Victoria to the Commission asking them to establish a clinical care standard because really things seem to be advancing much more rapidly for the care of patients with fractured neck of femur or fractured hips than they were for patients with emergency laparotomy. And the Registry for Fractured Neck of Femur has been very successfully supported by the development of a clinical care standard.
Clinical care standards include quality statements that describe best practice care as well as indicators. How does that work in practice?
Yeah, so what's really good about clinical care standards is that they look at the whole patient journey from arrival in hospital until they actually transition back to the general practitioner into primary care and either go home or discharge from hospital. And the standards pick up various stages in that patient journey, and the indicators allow health services and providers of care to see how they're performing against that standard. And I will say that there is a false perception that a standard is a sort of mandatory standard which you might be punished if you don't keep. They're actually aspirational standards that talk about what is best care, allow all of us who are treating emergency laparotomy patients to actually see how our health service is actually performing against those standards and continually improve against time. And that's exactly what's happened with that hip fracture clinical care standard as well, and with other clinical care standards.
So what areas of care does the standard focus on to drive better emergency laparotomy outcomes?
Well, if we think about what happens across the patient journey, the patient arrives in usually an emergency department or has an acute event when they're in hospital, and it starts off with really the assessment of that patient and the various things you need to do to come to a decision that the patient needs an emergency laparotomy. And so it covers things like the investigations you do, the time is of the great essence, so it's really about making sure that time is not wasted that would compromise the outcome for the patient. And there's a lot of information that can be got from a CT scan of the abdomen if the patient is well enough to have, and there's enough time to do that CT scan. And then there's the whole issue of assessing the patient's risk for a good outcome from the operation and making that part of the discussion with the patient around shared decision making, so that not every patient will necessarily be able to survive an emergency laparotomy, and there'll be a small proportion of people who might be better off not undertaking that and all that actually involves. And then we move on to not only the assessment of the patient in terms of their risk, but in addition to risk assessment, there's also, are they frail, and what's their risk of developing cognitive impairment, etc. All things that really affect the outcome in hospital. And then at the operation, do we have consultant, the most senior doctors available to actually treat the patient, so that the operation goes takes the right sort of time, has the right sort of decisions made, and the most senior people are around, because these patients, as I said, have a high mortality and therefore a high risk. And we're also promoting the involvement for higher risk patients in discussions with intensive care around, do they go to an intensive care unit afterwards? And that's a decision that's often best made before the operation, rather than doing it on the fly at the end of the operation. And that's probably the best thing for the patient. And then getting a geriatrician or a physician who's experienced in the care of older patients in the perioperative period is really important. It's been really good for hip fracture patients, and more than half of our emergency laparotomy patients are elderly over the age of 65, and many of them are also frail. So getting that geriatric input to their comorbidities and their other medical conditions is critical to the best possible outcome. And then obviously preparing for discharge and making sure that at that transition of care, the right sort of care is actually provided.
Chuan-Whei, the standard highlights shared decision-making and goals of care discussions. Can you tell us more about these and why they are important for emergency laparotomy patients?
Emergency laparotomies are extremely high-risk operations. They have a very high and significant physiological demand on patients. And so, as David has said, some patients will not survive an emergency laparotomy, and some patients who do survive may not survive very well. This leads us to the two core parts of Quality Statement 4, which is on shared decision-making and goals of care. So shared decision-making is a process. It's a discussion that is had between patients, families, and the clinicians, and it focuses on a patient-centered discussion about the likely outcomes of surgery and whether they will achieve the intended outcomes and also the patient's preferred outcomes. So it's a discussion that really highlights and establishes the patient's values, what their goals are, and what their preferences are for after surgery. These types of discussions are different from informed consent, which tend to focus on risks and benefits and tends to be treatment-centered. A shared decision-making discussion will discuss things like what's really important to you, is going home really important to you, maintaining your independence, and do we think we'll be able to achieve that after such a big operation such as an emergency laparotomy. The second part is goals of care. So goals of care are the aims of treatment that arise from a shared decision-making discussion. It's performed to help facilitate shared understanding between the clinicians, the patients and their families, and so that we can ensure that the outcomes we're looking to achieve after an emergency laparotomy are in line with the patient's goals. And that's particularly important with emergency laparotomy patients, because we know that of the patients who die after emergency laparotomy, 30 to 40% will die within the first 3 days. And although we're seeking to prevent deaths that result from a failure to rescue, we also have to acknowledge that some of these deaths will be in patients where it's a missed opportunity for high quality palliative care. And so this standard really looks to ensure that we're keeping all our decision making appropriate and patient-centered in a shared decision making model.
We've heard that frail and elderly patients are particularly at risk following emergency laparotomy. What does best practice care look like for older patients?
So older patients, particularly those who have a high degree of comorbidity and frailty, have worse outcomes related to mortality, lengths of hospital stay after surgery, complication rates, and they have higher outcomes related to not returning home, maintaining their independence, functional decline and cognitive decline. And so in order to support patients like this after surgery, the best practice care is multidisciplinary management. As David has spoken about, this really comes out of the hip fracture work and the really incredible shared care and multidisciplinary models that have come out of the geriatrician framework, along with nursing and allied health. So the clinical care standards look at this type of multidisciplinary model. In particular, we're encouraging the proactive collaboration and management with a physician, in particular a specialist geriatrician, and in the absence of having a specialist geriatrician, a physician, including rural generalists and GP hospitalists in the country, who have experience managing older patients after surgery. So what this looks like for best practice is really having a specialist that will be able to look at the many aspects of geriatric care, including a comprehensive geriatric assessment and the management of many geriatric syndromes such as frailty, multimorbidity, polypharmacy, functional recovery, and cognitive impairment. This is done in conjunction with allied health and nursing staff, and always in collaboration with the surgeons, pain management, and critical care physicians where that's appropriate for the patient.
What are key takeaways from the standard in relation to discharge planning and supporting patients' recovery following emergency laparotomy?
So we know from a lot of qualitative data as well as consumer input into the Australian Commission that patients after big operations and hospital admissions can feel very abandoned after that type of admission. There's often a lot of things that occur during that type of admission that can lead to recovery, long-term recovery in the community. These could be medication changes, these could be functional recovery, and even psychosocial recovery from such a big admission. And so this is the last quality statement in the clinical care standing, looking to transition a patient from the hospital setting back into the community. It really emphasises good written communication, both to the patient about what has happened to them, what they can expect, and who they can contact after they leave hospital, aside from appearing again in an emergency department. It also very much emphasises the community health practitioners that are extremely important in the ongoing recovery for these patients in the community, in particular general practitioners, but this may be also allied health staff and other community health practitioners, and that they should also receive the same type of written communication with the many changes that can have occurred in a patient's medical journey and the hospital admission, including medication changes and support for their functional and psychosocial recovery. This is a really important quality statement that came out of a lot of feedback and requests from both clinicians inside the topic working group, as well as feedback from consumers and other clinicians. And I think this is a really important and very unique aspect of the clinical care standards when we look at emergency laparotomy work in the world.
David, how does the standard apply in more challenging circumstances, such as when a patient requiring urgent surgery presents overnight, or if they present to a hospital without access to all the recommended elements of care?
Yeah, so look, the standard applies regardless of what time of day it is and where the patient is, but the standard also applies regardless of how much time you have to do the assessment and provide the treatment against the standard. And we have to recognize that there's a great variability in the urgency of patients undergoing an emergency laparotomy. Some of them will need surgery within a couple of hours, and others might be able to wait 12 or 18 hours before they have an operation. And so it's recognized that not every part of the standard can be delivered before care. We do believe, however, that patients can have a CT scan usually at any time, day or night, if they're in a hospital with a CT scanner, and that they'll be able to have blood test results and be able to get a surgical consultation with the emergency doctors. There are situations where patients will present somewhere where the ability to either do the emergency laparotomy or to do an emergency laparotomy on a patient with that degree of acuity or difficulty, and that will really require a discussion about whether to transfer the patient before the laparotomy, or whether to do something to try and stabilize the patient and perhaps control sepsis before transferring them. So it's absolutely essential, if a patient presents to a peripheral hospital that may not do many emergency laparotomies, that in fact there's a discussion between the senior doctor at that peripheral hospital and the senior doctor who's on call at the hospital to which they would be likely to refer the patient. And then included in those discussions has to be obviously the bed manager of the receiving hospital and the ambulance services to make sure that everybody's on the same page to get a patient who needs to be transferred with as much information known about the patient as possible, their degree of urgency understood, and the right things having been done before the patient gets transferred. And for patients who arrive in the middle of the night, we're not expecting them to see a geriatrician in the middle of the night. So some of the things that the geriatrician can provide can be provided in the first couple of days. And so we've actually in the standard said within 72 hours they should be seen by a physician experienced in perioperative care with the older patient or by a geriatrician with similar experience. And in the middle of the night, you have to but we would still expect a hospital doing many emergency laparotomies to have a consultant surgeon and a consultant anaesthetist not only available, but in the hospital, in the operating theatre, and the standard really promotes that. So yes, there'll be some things you can't do until later on, but the majority of the standard applies for the first part of the patient journey, which is making a decision about taking them to theatre, involving the patient in that decision, and being able to plan the right care for the patient immediately after the operation, as well as doing that operation with the senior people in the theatre.
In closing, David, can you share a personal experience of championing components of the care described in the CCS? How did this go, and what are some of the lessons learnt?
So one of the things that I've tended to champion is the importance of doing risk assessment beforehand. All of the papers that have been produced, and there are quite a considerable number now, show that if you do preoperative risk assessment, you do get better outcomes for patients, comparing patients with the same level of risk who actually haven't had that done preoperatively. And the National Emergency Laparotomy Audit on NELA score that's come from the UK is an example of one of a number of risk assessments that can be done, and it's the one that we have been promoting up till now in Australia and New Zealand, even though they've got a slightly shorter version that's now coming out. But the NELA score has an app, and I've been in Southeast Asia and Papua New Guinea and places promoting the NELA app, never mind in Australia, because I think that if people understand that the patient is high risk and they have a number, and that initiates a discussion between a surgeon, an anaesthetist, and often an intensive care physician, you're going to get a multidisciplinary approach to what will be the best care for that particular patient. So that's my experience, and given that you can do a NELA score in just about a minute, I've had lots of people in meetings downloading the app and doing the NELA score on the spot with one of my patients, just to see that it's easy enough to do.
Chuan-Whei, what is one piece of advice you would share with services starting out on this quality improvement journey?
I think it's really important to understand that this standard is a multidisciplinary standard. It was put together by a multidisciplinary group across a number of different disciplines, such as nursing, allied health, a number of different specialty craft groups. So in order to start out on this particular quality improvement journey, you probably need a multidisciplinary team, really representing all the stakeholders that were part of the clinical care standard topic working group that developed and provided guidance and advice for the standard. That requires you to identify champions in every specialty who are very passionate about this topic, who can speak to each other and collaborate, and also to really look at joining the NZELA QI audit, which is currently running and has been running for a number of years, because the audit and the clinical care standards really go hand in hand, and the audit provides the data in order to keep improving on the quality statements and the clinical care standard every year.
Thank you to my special guests, Professor David Waters and Dr. Chuan-Whei Lee. You can find more podcasts on our website at mja.com.au or wherever you find your podcasts. Thank you so much for listening.